Good morning, everyone. Thank you, Sudeep sir and Shona madam, for giving me this opportunity. So I'm covering three abstracts. So all will be on the use of gene expression profile signatures to escalate or de-escalate therapy in a ER-positive breast cancer. So this is the first abstract, the outcome of the patients with an ultra-low risk 70 gene signature in the MINDACT trial. So we all know that the gene signatures can identify patients with a low risk of distant recurrence who could be spared from chemotherapy. And for this MammaPrint, a threshold was established even within the low risk category, so which accounts for the 10 to 15% of all breast cancers. And in the previous studies, it was reported that these subset of 10 to 15% of breast cancers has almost 100% breast cancer specific survival at 15 years and almost 20-year breast cancer specific survival in a study by Swedish group showed that it was 97%. But the problem was all the reported previous studies had the numbers are too small, and this trial evaluated in a large cohort of patients. So these are the methods. So for all the patients, the clinical risk and the genomic risk were determined for the treatment allocation, and even in the clinical low risk group, they were divided into the according to the gene signatures. And we know that the MammaPrint 70 gene signature is divided into two risk categories where the index score of less than 0 is called high risk and an index score of greater than 0 is low risk. But even within this low risk category, an index score of greater than 0.355 is classified as an ultra low risk, and the median follow-up of this study was 8.7 years with a primary endpoint of distant metastasis free interval and the secondary endpoint of breast cancer specific survival. See, of all the patients of 6,600 patients, 70 gene signature of ultra low risk was seen in 15%, that is 1,000 patients, of which 75%, 3/4 of the patient had a low clinical risk, and majority had a lower size tumors less than 2 centimeters, with 80% of patients having a negative lymph nodal status, and almost 99% are estrogen receptor positive, and majority of the patients are estrogen HER2 receptor negative. And majority of the patients received endocrine therapy, but 16% of the patients received no adjuvant systemic therapy. So in this ultra low risk population, the distant metastasis free interval at 8 years was 97% compared to 94.5% in the low risk and 89.2% in the high risk patients. And the breast cancer specific survival at 8 years was almost 99.6% in this ultra low risk patient. And even in the clinically low risk group patients, the distant metastasis free interval was at 8 years was 97.6%, whereas it was 96.3 and 93.5% in low risk and high risk patients. So this is according to the clinical low risk and high risk, the distant metastasis free interval, and the breast cancer, it was almost 97.6 and 99.7%. And this is according to the systemic therapy received. Even in the patients who had not received any systemic therapy, they had an excellent outcomes with an 8-year distant metastasis free interval of 97.8%. And the outcomes for patients who received chemotherapy were slightly lower, which is only 95%. So in this large prospective study, patients with an ultra low risk 70 gene signature had the best prognosis, and patients had a reduced risk of distant metastasis free interval or breast cancer related death compared to the patients with low risk tumors or clinically low risk tumors. And the 8-year distant metastasis free survival is extremely good, 95 to 97.6%, and the breast cancer specific survival rates were almost 99%. The difference with this trial compared to the previous studies are in this the lymph node positive population also included, and the primary endpoint was the distant metastasis free interval compared to the BCSS in the other previous studies. But the problem is this trial has only a shorter median follow-up of 8.7 years. All the previous studies has almost 15 to 20 years. But the disadvantage of this trial are it is only an exploratory analysis and the no random assignment to treatment specifically was done, and hormone receptor positive patients are known to recur late, and a longer follow-up is needed to reliable assessment of the BCS. So this can identify, this 70 gene signature can identify ultra low risk patient which has a very extremely good prognosis, but a longer follow-up is needed to reveal whether this excellent prognosis continues, and the patients can be considered for further de-escalation of the treatment. And this is the second abstract, the endocrine therapy response and 21 gene expression assay. We know that chemotherapy can be safely omitted in oncotype DX low risk population and a subset of intermediate risk population too. But this is the first trial which has used the oncotype DX on the biopsy specimen and also the endocrine therapy response to omit the chemotherapy in the intermediate risk group, because we all know that the recurrence score is substantially driven by estrogen related features and less by the proliferation markers, which underlies the potential clinical utility of this trial to incorporate both recurrence score and proliferation. So these are the methods. In this, along with the Oncotype DX scoring system, the endocrine response is defined as the post-endocrine therapy for 3 to 4 weeks of therapy. If the Ka67 in the biopsy specimen or in the resected specimen, if it is less than 10%, it is considered as an endocrine responder. So this is the total population group with a primary endpoint of invasive disease-free survival, and the secondary endpoint of distant disease-free survival and the overall survival. A total of 5,600 patients are analyzed. Majority of the patients had a recurrence score of 12 to 25, and 1/5 of the patient had a low recurrence score. So of all the patients, so the endocrine responses, that is the post-operative Ka67 less than 10% was seen in 60% of the patients, and the majority of the endocrine responses are with AI compared to the tamoxifen. So this is the, we can see that the recurrence score is significantly associated with the endocrine response. And in the trial population, this endocrine trial population of 2,162 patients, so 68% has endocrine response, of which 86.7 are with AI and 48% approximately were tamoxifen. And this is the control group where the recurrence score of 0 to 11 and the intermediate risk group with endocrine response. The outcomes of invasive disease-free survival, the disease-free survival and the overall survival are almost similar between both groups. And this is according to the age. So the invasive disease-free survival and the distance-free survival. Even in patients who are less than 50 years of age, the survivals were similar between the control group and the experimental group. And it has met the pre-specified non-inferiority criteria of, and according to the age also similar. And to conclude, this trial has told that for the first time, it prospectively combines both the research using the gene expression profiling along with the response to the endocrine therapy. And in both endocrine trial arms, they had an excellent invasive disease-free survival with endocrine therapy alone, and chemotherapy can be safely omitted in them. So my take, this is the independent of their age, a substantial proportion of these patients can safely be treated with adjuvant endocrine therapy alone. And not only patients with 0 to 3 involved lymph nodes and low recurrence score, but also patients with limited nodal burden and intermediate risk score and had a good response to endocrine therapy, we can safely omit chemotherapy in them. So recurrence score testing together with endocrine therapy response could thus pair chemotherapy for more than half of the patients with high clinical risk and up to 3 involved nodes who are candidates for chemotherapy by conventional clinico-pathological criteria. This is the next abstract, the utility of 70 gene mammoprint for prediction of extended adjuvant endocrine therapy in the ideal trial. So we all know that 10-year endocrine treatment benefit is modest and it is associated with some side effect. So whether we can use the mammoprint test and predict which patients can benefit from this extended endocrine therapy. So this is the previous NSA BP42. We had shown that the low risk mammoprint patients significantly benefit from the extended adjuvant therapy. And this is the ideal trial where 2.5 years of letrozole was compared with 5 years and had shown that there was no statistical differences in the DFS and the distant metastasis-free survival. And this is the translational mammoprint cohort study based upon the mammoprint risk scoring, whether is there any subset of patients who can benefit from the extended adjuvant endocrine therapy of more than 5 years. This was the primary objective, was to identify patients who are likely to benefit from the extended endocrine therapy for distant recurrence, and the secondary objective is to assess the recurrence-free interval and the breast cancer-free interval. This is the translational mammoprint cohort study, which was almost similar to the whole ideal cohort study, and there was a significant extended endocrine therapy benefit for distant recurrence in the mammoprint low-risk tumors, but not in the high-risk tumors. Also, the recurrence-free interval was significantly better in the low-risk tumors, and mammoprint low tumors derive the most significantly benefit from the extended endocrine therapy for the recurrence-free interval compared to the high-risk tumors. So these are almost a difference of 10% absolute benefit of 10 percentage points in the low-risk tumors, but the high-risk tumors didn't benefit from the extended endocrine therapy. So the mammoprint high-risk breast cancers don't derive a statistically significant benefit from extended endocrine therapy, and they're likely due to, this is likely due to the early risk of recurrence and reduced sensitivity to the endocrine therapy. Whereas ultra-low risk tumors, as we have seen in the first abstract, they have a very good survival and they don't derive any benefit from the extended endocrine therapy. But mammoprint low-risk tumors, they are endocrine sensitive and they derive a very significant benefit with the extended endocrine therapy, with a 68% risk reduction in distant recurrence and 63% risk reduction in the recurrence-free interval. So the mammoprint is predictive of the endocrine benefit and the low-risk population. significantly benefits from the extended endocrine therapy. So to conclude my take, so on the 3 abstract, the MammaPrint ultra-low risk patients will have an excellent survivals, and de-escalation of systemic treatments can be attempted in those groups, and chemotherapy can be safely omitted in recurrence score 12 to 25 patients who had a significant response to endocrine therapy, irrespective of the age and nodal status. And MammaPrint low risk patients definitely benefit from extended endocrine therapy, but not high risk patients. Thank you.